Welcome to Intensifying Treatment for Type 2 Diabetes according to current guidelines, an office hours activity. My name is Dr. Vanita Aroda from Brigham and Women's Hospital and Harvard Medical School. I'm so happy to be here with you today. I want to thank PeerView for providing the session and to Lily for providing the educational grant for the symposium. Throughout this presentation, please watch for additional follow-up polling, and you can submit your questions using the chat feature. I will be answering them live in the chat during the first 30 minutes and live on your screen for the office hours portion in the second 30 minutes. You can view and download today's slides and helpful practice aids on the PeerView website. Let's begin. Our goals for today. We want to augment your knowledge of the long-term consequences of therapeutic inertia, meaning the failure to intensify treatment in people with type 2 diabetes. And we hope to equip you with strategies to intensify treatment to help people with type 2 diabetes reach their glycemic and weight loss goals. Time is of the essence, so let's begin. We have no time to lose. Intensifying type 2 diabetes treatment to minimize complications. The neat thing about being part of educational activities is even now the educational activities are evidence-based. So what you see here is that today's webcast was designed to fill gaps exposed by other recent CME activities on type 2 diabetes and weight management. So in those in previous activities who answered correctly, they were able to recognize that timely intensification is linked to improved patient outcomes. They were able to cite evidence-based rationales that are aligned with the guidelines. They said that they needed suggestions to balance the real-world treatment challenges. Those who answered incorrectly in previous CME activities recommended less effective agents, focused on agents that with modest benefits, and didn't anticipate the patient willingness to select the newer or optimal agents. And in those who were unsure of their answers, there was hesitation to commit to more aggressive or more intensive treatments, and they preferred more time to meet goals, maybe additional lifestyle changes. This is all familiar to many of us, and there is uncertainty around newer agents as well as current goals. So let's address this. Consequences of clinical inertia, starting with the comorbidities and complications in persons with type 2 diabetes. What do we mean by clinical or therapeutic inertia? You've probably heard this term in many different contexts. What therapeutic inertia refers to is the delay or inaction to initiate or intensify therapy when glycemic treatment goals have not been met and are clearly indicated. So something should be done, but it's not being done. And this means that it could mean being slow to add or change the care plan if the patient's A1C is too high relative to their target. That care plan may include medications. It could include health checks, diabetes education, nutrition therapy, exercise, and emotional support. The American Diabetes Association advises clinicians to advance therapy if a patient doesn't get to goal within 3 to 6 months. And this has been part of the standards of care since the first standards of care was published a couple of decades ago. But what we've seen is that despite the availability of therapies as well as other approaches, studies show that it can often take more than a year to intensify treatment, and time is of the essence. To give you a snapshot of how important the time in treatment intensification is, here's a snapshot looking at the cardiovascular risks of a 1-year delay in treatment intensification in individuals who have an A1C of above 7% or less than 7%. And as you can see, there's a dysglycemic legacy that starts from the get-go, that starts from diagnosis. So here, both groups had a baseline A1C on average of 8.1%, but in those who intensified treatment and had a lower A1C compared to those who did not intensify treatment and had a higher A1C, there's a discrepancy in long-term cardiovascular risks. At 5.3 years, there's a higher risk of MI, stroke, heart failure, and composite cardiovascular events in those with an A1C of 7% or greater without treatment intensification. Now, what we've seen, again, consistent across all studies, is that early glycemic management matters. This is from the Diabetes and Aging study, and I call this the glucose pack years concept, where what you see is compared to within that first year of diagnosis, compared to maintaining an A1C of less than 6.5%, even a slightly higher A1C in the blue circle a 6.5 to less than 7% is associated with an increased risk of microvascular, macrovascular complications, and mortality. And that risk increases as we get to higher magnitudes of A1C, above 7%, above 8%, and above 9%. Now let's increase the exposure time. What happens if you have increased exposure to higher glycemia over 2 years, 3 years, all the way up to 7 years? You can see an amplification of effects. So you see a cumulative risk based on glucose exposure. Hence, the time starts from the diagnosis. We also see in a lot of epidemiologic studies that early weight management matters. Here you see from large cohort databases the increased risk of cardiovascular disease, morbidity, and mortality in both men and women, going from healthy weight in green to overweight in orange to obese and severely obese. What's also been seen in some studies is with underweight, you can have a U-shaped curve or a J-shaped curve. So there could be some differences in populations or individual cultures, but the trend remains the same, is that the higher body weights do translate to higher risk of complications. And what we've also seen from large epidemiologic studies is that early weight management matters. Here you see from large cohort studies that increased body weight in both middle-aged men and middle-aged women is associated with an increased lifetime risk of cardiovascular disease, morbidity, and mortality. And what we see is that the lifetime risk for total cardiovascular disease exceeded 30% for men and women in all BMI groups, that participants in higher BMI strata had higher lifetime risks for cardiovascular disease through the age of 95. However, all-cause mortality was higher for underweight individuals. So keep that in mind as you tailor it to the individual in front of you. So now before we move on, let's take a moment to answer a follow-up poll on early management of glycemia and weight. Next, let's explore glycemic and non-glycemic effects of therapeutic options. So what a day and age we live in where, it used to be where all drugs were kind of created equally, but that's not the case in diabetes. And what we have now is comparative efficacy studies and network meta-analyses that really kind of give us a snapshot of the differential efficacy of the glucose-lowering regimens that are available. What you can see here, this is a meta-analysis published this year looking at some of the higher efficacy treatment approaches. This one is looking at tirzepatide, which is a GLP-1 and GIP dual agonist, as well as GLP-1 receptor agonist in combination with basal insulin, as well as GLP-1 receptor agonist in combination with SGLT2 inhibitors, as well as the high-potency GLP-1 receptor agonist. And you can see that we have a higher potency in terms of change in A1C and change in body weight with the tirzepatide or with the combination therapies. So we're definitely entering a new age of efficacy with the agents that are in existence. And compared to the olden days where we had higher risk of hypoglycemia, especially with treatments involving insulin, we are now able to nearly eliminate that risk in our patients with type 2 diabetes, dependent on the therapies that we choose. I love this heat map that we put together, really to show you the differences of the different incretin-based therapies, the GLP-1 and the GIP, et cetera, based therapies in terms of their effects on A1C lowering, as well as body weight. And what you can see is that we are definitely entering into a generation of higher potency agents that are able to see greater A1C reductions. We have the highest potency with semaglutide 2 milligrams weekly or tirzepatide at 10 and 15 milligrams weekly in both A1C reductions as well as body weight reductions. Now, how do we translate that at the bedside? One of the conversational points that we often have with patients in terms of goal setting is the impact of weight loss on some of the medical comorbidities. What we're all used to and we've all been trained is that 0 to 5% and 5 to 10% of weight loss can improve blood sugar, it can improve blood pressure, it can improve lipids, it can improve menstrual cycles, for example, in PCOS. But what we're also starting to see with some of the outcome studies is that once you achieve 10 to 15% or over 15% weight loss, we are now seeing the ability to impact disease modification or disease course. So in goal setting, we can aim for what our target weight loss is, depending on what the goals are. What's also exciting in the field of metabolic therapeutics is that even the current incretin-based therapies are more effective than the traditional weight loss pharmacotherapies that we've seen. So here we have the mean weight change from baseline with tirzepatide, higher dose semaglutide, phentermine topiramate, liraglutide, naltrexone, bupropion, and orlistat. And you can see that we've definitely entered an amount of weight loss where we can modify disease course. So now let's switch gears to the American Diabetes Association Standards of Care, where I've been really privileged to be a part of the process. So in 2022, the ADA and EASD in combination issued this consensus on approach to glycemic management in type 2 diabetes. And I was privileged to be a part of that process, focusing on the therapeutic section. What we all agreed upon is that the goals of care start with the person at the center. Their goals are to prevent complications and to optimize quality of life. We also realize that there are many principles of care that we need to recognize in order to support the person at the center, including, for example, shared decision-making, paying attention to our language, making sure that there's structured education, support, that we're looking at the whole picture of not just medications, but also health behavior modification. In terms of medical approaches, these are the 4 cornerstones that we focused on. One is making sure that we support glycemic goals through our glycemic management and the medications that we choose. 2 is recognizing weight management as a co-primary to glucose management and addressing it through any number of evidence-based tools that we have. In addition, not to forget that type 2 diabetes does increase the risk of cardiovascular disease, and therefore it's important to pay attention to and focus on cardiovascular risk management. And lastly, we have entered the era of the cardiovascular outcomes trials where we do have 2 classes of medications that can support cardiorenal protection. In other words, reduce the risk of cardiovascular disease and kidney disease. So there are specific agents within the GLP-1 receptor agonist class and the SGLT2 inhibitor class that has evidence to do so. I'm going to break it down a little bit further. So if we look at the algorithms in the international consensus, there are different buckets. So different agents of medications for the different health priorities. For the goal of reducing ASCVD risk, we again know from the CVOTs that there are specific GLP-1 receptor agonists and SGLT2 inhibitors with proven cardiovascular disease benefit. They are listed here. In terms of reducing A1C, we were very deliberate in the language that we chose here. We will all recall that in previous iterations of guidelines, the foundational therapy was metformin, and add a second therapy, add a third therapy. Here we said, keep the eye on the goal. Choose approaches that provide the efficacy to achieve goals. This may be metformin, this may be combination therapy, this may be a choice from any of the tiered therapies from very high to intermediate efficacy. So choose your agents that will help support patients getting to goal and maintaining the goals. We also included language on recognizing the importance of weight in type 2 diabetes and long-term outcomes. And so in persons with type 2 diabetes, where weight is part of the picture, the preferred pharmacotherapy should be a GLP-1 receptor agonist or a dual GIP-GLP-1 receptor agonist with greater weight loss efficacy. And we tiered the levels in terms of efficacy on weight loss, with your very high efficacy being semaglutide or tirzepatide, and then followed by high, intermediate, and neutral. So now that we've had all this progress with therapies, how are we doing? If we look at the different databases, we see that over time, from 2011 to 2021, our proportion of patients achieving A1C goals hasn't budged too much. Here we see A1C in adults with diabetes and an A1C of less than 8% that is essentially unchanged over the last 10 years. And so this has been a high priority for the American Diabetes Association because the ADA publishes its standards of care every year, but what good is it if we can't keep up? And so despite more drugs, despite more education, despite more technology, the average A1C hasn't changed. And in terms of complications risks, what we worry about is that the number of persons with type 2 diabetes with an A1C over 9% has actually increased over the last 20 years. The ADA has established its OTI movement, Overcoming Therapeutic Inertia, and I really want to recommend the resources on the American Diabetes Association website, including this 5-minute video, which is highlighted here. And that is, just some bullets on treatment intensification. We know that only 5% of persons with type 2 diabetes on Medicare use diabetes self-management and education services, for example. We know that reaching A1C targets soon after diagnosis predicts better long-term control. We know that persons with type 2 diabetes say they are willing to do more than their physicians believe they will do. So there are a lot of findings and a lot of areas that we need to work on. And we also know that less than 50% of persons with type 2 diabetes continue or persist on glucose-lowering medication after 1 year. Lots to work on. So let me highlight for you now the OTI initiative, the ADA Overcoming Therapeutic Inertia Initiative. Again, lots of resources on the American Diabetes Association website, but I want to highlight the 3 main bubbles of focus. 1 is in research. 2 is in collaborative barrier busting, realizing that we can't do it alone. It really does take a supportive network and alliance. And then 3rd is education and awareness to promote clinician success. The website has a lot of great wisdom and tools that one can download and incorporate into their own practice. I'm going to highlight a few pearls that I think are particularly valuable in terms of understanding the impact of therapeutic inertia on persons with type 2 diabetes. One of the recommendations that I feel strongly about is to schedule diabetes-only visits so that you know what the focus of the visit is and it becomes a shared goal for the patient and the clinical team. And so we know that if we can focus on diabetes, we can really impact long-term outcomes in other health areas. Also ask office staff to remind patients to bring their glucose logs, list of medications, monitoring devices. Aim to adjust therapy when the A1C is not at goal. Set that as part of the expectations. It's no fault, no guilt of anyone at all, patient or provider, but keep the eye on the prize of A1C. And consider making changes between A1C tests based on monitoring results. Another area is it's important to recognize when there are barriers. So to recognize therapeutic inertia, check for barriers. Is there diabetes distress? Is there depression? Is there low health literacy? Are there social determinants of health impacting advances in care? Another common technique that we use in practice is to schedule the follow-ups based on where you're at. So if the A1C is quite high, schedule a sooner follow-up, for example, 6 to 8 weeks. If the A1C is a little bit high, 7 to 8.9%, schedule it modestly sooner, every 2 to 3 months. Only when they're stable, then you can have the follow-up scheduled every 3 to 6 months, for example. And in terms of planning with patients, develop a diabetes care plan that includes a personal A1C target. Let everyone know what the goals are of care. Take into account the patient needs, the patient morbidities, concerns, and wishes, and review the target goals with the patient on a regular basis. Also, it is recommended that all patients should be referred for diabetes self-management education when diagnosed or if they've not received this before. I highlight here for you the American Diabetes Association campaign to overcome therapeutic inertia. They started with a call for applications for grant proposals and ideas a few years ago, and have really developed an elaborate website with toolkits based on the learnings, as well as lots of educational programs. So you can explore the toolkit, look at the insights, and listen to the webinars and podcasts highlighting the community of experts. Here's one publication that I want to highlight, showing some of the research areas that are in place to try to overcome therapeutic inertia. One is looking at care management and patient education-based approaches, including virtual patient coaching, self-management education, glucose telemonitoring as examples. There have also been physician-based programs throwing additional education towards the physician. So looking at education regarding guidelines, in-person training and support from specialists, and face-to-face feedback, as well as computerized or digital reminders. Two of the most promising that in terms of study data are nurse or CDCES-based approaches as well as pharmacist-based approaches. Now, in both instances, there's evidence-based guidance and protocols that the clinical team can use to support helping patients get to goal. And what I found interesting in this publication is that if you just utilize education alone, Without the intensification protocols, you're less likely to get effect as opposed to marrying the treatment titration protocols with education. What other models are there? So here's a publication that I appreciate from Mosenson and colleagues, where they said, you know what? For most patients will be at higher cardiovascular risk. For most patients, you can approach a simple algorithm, and that is looking at lifestyle modification, education for all. And for most patients, they'll benefit from foundational metformin and as well as disease-modifying therapies, your GLP-1 receptor agonists and the SGLT2 inhibitors, where there are outcome studies demonstrating their benefits in ASCVD, in heart failure, and in chronic kidney disease. And for patients who are in a catabolic state or have symptomatic hyperglycemia or an A1C is elevated above 9%, that's where you incorporate your quickly effective therapy of basal insulin. And another model that I want to highlight is done at Vanderbilt. So this is the Vanderbilt Collaborative Diabetes Management Model, recognizing that there are a lot of patients with diabetes and perhaps not as many specialists. So here's a tiered approach where all patients with diabetes in the panel are seen by the primary care provider. If the patient is meeting their goal, they continue to follow up. If there's evidence that assistance is needed or the patient is not meeting the goals, they're referred to a 12-week program focusing on diabetes self-management and education support, as well as medication optimization. And then for the complex patient, there's an open dialogue and referral to the specialist. So this would be the endocrinology referral. For example, in someone with refractory hyperglycemia, comorbid complications, severe hypoglycemia, severe insulin resistance, or refractory hyperlipidemia. Before we move on, please take a moment to answer a follow-up poll on overcoming therapeutic inertia. And now let's switch to patient misconceptions and beliefs about treatment intensification. Why do patients resist therapeutic intensification? I think we can all think of anecdotes that come to mind from our own personal experiences. Here are some highlights from the publications listed below. A meta-analysis of 8 studies of medication beliefs among persons with type 2 diabetes found concerns about general worries about adverse effects, general worries that medications are overused, specific worry about the necessity of a medication, specific worries about a particular medication. Importantly, these concerns are listed as moderate, suggesting amenability to change through education. We also appreciate that therapeutic intensification may be resisted by persons with type 2 diabetes who weren't told that the progressive addition of therapies is expected, who view intensification as punishment for poor self-management, who feel that intensification represents worsening health, who are self-managing multiple chronic diseases, or who have difficulty affording their medications. So these are some helpful tactics for increasing patient comfort when intensifying type 2 diabetes treatment when needed, the top 5. And I really want you to think about your own patient examples because we've all had these conversations and dialogue. So many patients want to know how the medication will affect them more than how it works. So take the time to explain to help the patients know what adverse events might occur, how to take the medication, how it might reduce long-term risks, the benefits and risks of the different medications, make it a shared decision-making process, and how it might fit the needs and lifestyle. Also, what's been shown in this survey is that primary care physicians need to be more comfortable with the medication and have a supportive team to help them. We can't do it all alone. So really think about your team-based care, your shared care model, CDE or others that can support teaching, EHR alerts, time-saving strategies, and assessing time and range with CGM. Technology really may be able to change how we care for patients. So some helpful clinician strategies to initiate and persist on insulin and other injectable medications. There's things that we can do throughout. So at diagnosis, what do they believe about type 2 diabetes or about the medication? Explain the importance of glucose control and that treatment might evolve over time to include insulin. Prior to insulin initiation, gauge perceptions of insulin treatment. Explain benefits tailored to pre-existing perceptions. reach agreement on the necessity and the why of insulin therapy. At initiation, reiterate insulin's benefits, demonstrate injection process, offer support that they are not alone in this process. And then even following initiation, ask about the experience with insulin, changes in energy, mood, weight, and ask how injections are fitting into the daily routine. Living with chronic disease can be difficult. And so this is where we need to make sure that we don't go down the vicious cycle of failure and that we can convert to a virtuous cycle of success. And what I like to think of it is trying to have an anchoring habit. So one positive change. The moment we have one positive change, it contributes to a cycle of additional positive changes. And we've seen this with GLP-1 receptor agonist-based therapy. So if we set realistic goals using the SMART goals, specific, measurable, achievable, realistic, and timely, when we make an effort and attempt some modification, some either in glucose monitoring, exercise, dietary changes, when that goal is met, guess what? It's empowering. The distress is reduced, meaningful benefits are noticed, and then there's greater adherence. And it's a positive feed-forward cycle. So let's take a look at some of the practice aid demonstrations to help clinicians apply the latest guidelines on weight management in persons with type 2 diabetes. This looks like a lot of detail, but I want to highlight a few things. One is that we are all in this together. It's an iterative cycle. And then two is that there are key principles that we do need to enforce, and there are conversation tips on how to do that. So we know that the nature of type 2 diabetes may change over time. So we need to set the stage for that. Treatment plans may change over time. Weight and health affect each other. These are all integrated with our full cardio, kidney, metabolic morbidities. And patients can't do it alone. We're in it together, and we should be encouraging patients to share difficulties. The healthcare team is here to help. So I highly encourage you to look at some of the conversation tips and keep these at your disposal. Also looking at SMART goals. So how do we make goals specific, measurable, achievable, relevant, and time-bound? It takes goal setting, conversation, even something as what might seem simple as eat healthier. Let's get granular. So including at least 2 servings of vegetables daily, keeping a food diary, starting with familiar vegetables, making sure that why they're doing it is relevant, and then evaluating in a time-bound manner. As one example. Here's, again, the heat map, so you can have an understanding of how the different therapies, the incretin-based therapies, can match the A1C lowering and the weight loss goals for your individual patient. We've covered a lot of material, so I want to highlight here the key takeaways on intensifying therapy in persons with type 2 diabetes. It is important to recognize when glycemic and weight goals are not being met, and not to wait more than 3 to 6 months before intensifying or adjusting therapy. It is important to provide anticipatory guidance to patients about the potential need to adjust therapies over time. We're also in a really privileged era that we know that multiple health goals can be addressed by medications, including the GLP-1 receptor agonists, the dual GIP GLP-1 receptor agonists, and SGLT2 inhibitors, which have demonstrated disease-modifying capabilities. Many strategies have been evaluated for overcoming therapeutic inertia. Find ones that have been tested in clinical settings like yours and give them a try. And finally, nothing succeeds like success. Help patients set SMART goals and initiate a virtuous cycle of diabetes management. Before we move on, please take a moment to answer a question on your practice strategies. That concludes my presentation for today. Thank you very much for joining me. Now it's your turn. Please stay on the line and I will answer as many of your questions and challenging cases as possible. After that, don't forget to complete and submit your post-test and evaluation for credit and to download the slides and practice aids. Also watch for the online version of this activity in the coming weeks and the final webcast in this office hours series beginning on January 15th. Thank you. Hello, everyone. It's office hours time. It's been such great online dialogue, and now this is live dialogue. So keep sending your questions. You can see me, though I can't see you. So let me see you through your words and your questions. I want to pick it up from a couple of the anecdotes of people who with high A1Cs, 10.2, 12.7, where you're thinking about the treatment options. And sure, true, when people are in a catabolic state where they're symptomatically having hyperglycemia, blurry vision, increased urination, increased thirst, we really want to get the glucose down. So insulin, it should be under consideration for those individuals. However, what you're seeing is that we're not committed to the long run. So we can think about a GLP-1 receptor agonist or a GLP-1 GIP dual agonist because they have the greatest efficacy in supporting glycemic control. But we can also, incorporate metformin. The insulin doesn't have to be a lifelong treatment at that point, but it could be the short-term treatment as you then incorporate and transition to other therapies. I also want us to never forget metformin. It's such a strong foundational therapy, really good metabolic control, 1 to 2% A1C reduction, supporting modest about 2 to 3 kilograms of weight loss, or at least not weight gain, and potentially long-term benefits. So even when people feel as if they've graduated to insulin, there's still metabolic benefit with reintroducing or keeping the metformin on board. So more questions I'm seeing. Patient was not reaching goals, or comments or your own experience. Patient was not reaching goals with current therapy, and we decided to add a GLP-1 to help improve A1C and also assist with weight loss. Yeah, we see that a lot in clinical practice where people have tried and feel as if they've, quote, failed other therapies. And it's not necessarily a failure. It's just that diabetes is a complex, multidimensional entity, and sometimes it takes targeting the different pathways. What you also see with the GLP-1 receptor agonist and the dual GLP-1 GIP agonist is with the weight loss and the glucose control, you also have benefits on cardiovascular risk factors where you'll see blood pressure improve, lipids improve, in particular lipids that are associated with obesity, such as your triglycerides and your HDL. And then with some of the studies, we see cardiovascular protective benefits in certain populations with some of the agents. So what else? I love the comment on, describing insulin as a hormone that the body itself makes, and this is really supporting what the body is already doing. I think it's really important to think about the language that we use. So we're not treating failure, but we are supporting what we see with the tools that we have. Same thing with the GLP-1 and the dual GLP-1 GIP agonists. They are based on some of the natural hormonal physiology that may not be working as much anymore. So what the GLP-1 receptor agonist class does, it enhances the body's own sensitivity and sensing of glucose. So then the normal circuitry can happen more effectively. I am seeing lots of comments. So patient today with type 2 diabetes and A1C. Oh, we did that one. Okay. Patient was not reaching goals with current therapy, and we decided to add a GLP-1. Yep, we've got that. Okay. I thought I saw one about heart failure. Well, that comment disappeared, but I will go ahead and ad-lib. So what we are seeing more commonly is that diabetes itself does increase the risk of heart failure. And what we're seeing across the studies is that patients with type 2 diabetes, and even those without type 2 diabetes, if they have heart failure, whether it's preserved ejection fraction heart failure or reduced ejection fraction, benefit really remarkably from the SGLT2 inhibitor class, where we see 30 to 35% reduction in hospitalizations for heart failure. We've also seen now with the STEP-HFpEF trials, improvement in symptom score with semaglutide. So this is, again, an evolving area. There it is. Okay. Patient with type 2 diabetes and CHF on oral anti-glycemics did not want injectables. Discuss adding Jardiance for CV reduction and renal protection. Absolutely. I mean, these really, we're seeing in multiple studies, they not only reduce the hard outcome of heart failure hospitalization, but also the symptom score associated with heart failure. And now let's see more comments. LDL drop with Mounjaro now too for CV safety. Yeah, so we are all eagerly excited and awaiting the SURPASS CVOT study, which will be, according to clinicaltrials.gov, it should be completed in May of 2025. And what that is looking at people with established cardiovascular disease and comparing tirzepatide versus dulaglutide in a blinded randomized controlled fashion with, enough events for us to be able to say, is there additional advantage of the dual agonist compared to the GLP-1 receptor agonist? We already know from the REWIND study that dulaglutide reduced the risk of heart disease, and also secondary analysis showing improvements in other aspects, including renal function, lipid parameters, possibly even an effect on stroke and dementia, for example. What are some other scenarios that you all encounter day to day? Ooh, lots more coming. Started patient on Mounjaro to achieve better type 2 diabetes control. This has been really interesting, Patrick. And I think, again, I really value my time on the guidelines because when we all learned, the very first iteration of the guidelines was you start one with metformin, then you add drug number 2, then you add drug number 3, and then you add drug number 4, then you go, gangbusters with your most potent agents. What we did in this iteration is let's look at the patient in front of us and use the tools appropriately. Just yesterday, I saw someone who was started on tirzepatide and lost 40 pounds, and you could see markers of disease regression. And I think that's where the future is starting to head towards is, can we start modifying the disease course? The way we all learned it from the UKPDS is that diabetes is chronically progressive. It's going to get worse over time. You're going to have to keep adding medications. Well, I think at this point now it's matching the medications to the outcomes that you're trying to treat, such as for the heart failure with the SGLT2 inhibitors, sleep apnea. There's a large study, the SURMOUNT OSA, showing, again, improvement in sleep apnea markers with tirzepatide. So I think we are in an exciting day and age. Okay, so now I'm just reading your comments live, patient with A1C of 12 starting patient on Toujeo. I believe that says Toujeo. Toujeo is referring to insulin U300 glargine, which again is one of our longer acting basal insulins along with insulin degludec. And what we're seeing there is with each iteration of the basal insulins, we're getting to match more physiologic control. So we are now able to replicate the true basal. A few things that keep in mind with insulin is it's there to replicate the true basal. So basal insulin doesn't cover the prandial needs. So you really want to think about some of your agents that cover more prandial needs. And this is shown really nicely if you use CGM in this patient population, which we do recommend for people who are treated with insulin. So your incretin-based agents have a nice effect on your postprandial blood sugars. Prandial insulin can be thought of and invoked if you're seeing very significant postprandial rises. It's really an exciting time to really look at the patient in front of you, the CGM data, if you don't have it, to say, okay, let's take a look at what your glucose profile looks like. One of my colleagues uses the term glucotype. Let's glucotype you. Let's see, is it more of a basal defect? Is it more of a prandial defect? Let's see what the different foods are doing. If we switch from white rice to brown rice or quinoa, do you see the same kind of spikes? And that data that the patient sees themselves is extremely empowering. Okay, more questions, comments, and your own experience. I am scrolling down. I think just going back to the chat, there were some comments on fear. So fear of insulin, fear of, dying. That there really is fear, a sense of fear and sense of guilt that we sometimes see with diabetes. And I think what we can do is offer our support that, hey, you know what? That we're actually all in this together. So making sure that they don't feel alone in their process and really helping to dispel some of the fears. just people know the myths of, oh, my aunt had insulin and then had her leg amputated. Well, we all know that the insulin didn't cause the leg amputations because the therapies were so limited at the time, and insulin really was used as a last resort. But we have a lot of trials, the head-to-head trials, looking at our potent agents early on in the course of disease. So that model, again, that paradigm is shifting. We're not necessarily saving our most potent agents for the end, but really starting to think about them and utilizing them early on when indicated. More comments in the chat. Patients often ask about newer treatments with recent GLP weight loss craze. Oh my gosh, we are seeing this galore. I mean, some of you guys have probably experienced the demand and shortages. It's been a mixed phenomenon. So initially it was, again, really a struggle with, drug X being not available. Then what do you do? And so eventually over time, we've come to realize that you can kind of interswap the different incretin-based agents. There are a couple of nice publications out there that, based on the pharmacokinetics, gives you somewhat of a dosing guidance of how you might switch from one to another. Realize that, each of these agents have different potencies, so you don't want to go from a modest dose of one agent to a strong dose of another. You want to go to more comparable. And the other kind of pearl that I do is if I don't know, I'll still start them on the lower dose, but just accelerate more quickly to find their new steady state dose. The other interesting that's happened because of the weight loss craze is these agents are so much more familiar to the broad public that, whereas 5-10 years ago, we would really have to spend a lot of time educating them about these newer agents, the mechanism of action. There's a certain amount of familiarity that the public has with these agents. So I think that's been interesting and overall positive. So it allows us to spend more of our time talking about how the medication might work with them, what to look for, and how to monitor over the long run. I'm seeing a comment from Andrew, discussed a med change with the patient to add a therapy for more weight loss. The patient refused any shots and got oral GLP-1 for this. So that's an excellent point. Oral semaglutide is the first GLP-1 now approved for oral use based on the findings from the Pioneer trials. I was an investigator part of those, really showing preserved efficacy of within the oral GLP-1 class. And then top line results have been released to the public on the SOUL trial, which is the cardiovascular outcome trial with oral semaglutide, showing positive benefits. So I think we're eager to see what the peer-reviewed publication and the results show. Patient not doing well on glipizide metformin was added Mounjaro. So and thank you for sharing that experience, Kiara. What I would say here is, again, in the past, we got used to adding. Now I tend to think of more incorporating. So as you're incorporating the tirzepatide, you can think about whether or not they will need the glipizide in the long run. So what I've started to do, and many of my colleagues do, is I give people down titration instructions. And the concept I invoke here is lifting the pedal off the brake. So what we do know is that the incretin agents are glucose dependent or glucose smart. They kick into action, kick into gear when the glucose is high to enhance the glucose sensing by the pancreas. And so it's hard to do that if you've got the glipizide and the insulin constantly revving up the pancreas as is. So, loosen that brake a little bit. So depending on what their A1C is, if their A1C is less than 8.5%, I might cut the dose in glipizide in half as I'm incorporating the tirzepatide or the potent GLP-1 receptor agonist. And then I might tell them, okay, as your fasting glucose goes below 100, you can cut your dose of glipizide in half again and then wean to off. And what you see, it's kind of like a little teeter-totter effect. As you incorporate these potent agents, you can start weaning down to off and swapping out the regimen. I am Jennifer Evans. I think I'm going to love this comment. Let's see. I feel like personalizing care, i.e. glucotype, I love that term too, will help patients feel heard. They will also understand the diabetes process unique to them. Absolutely. And and again, this is just kind of subtly happening day to day where it's less paternalistic in terms of telling people what to do, whereas let's see what you're going through. Let's see what a typical day is like for you. And here's what happened, the day after Thanksgiving when, these foods affect you in a certain way. Just pulling from an example from yesterday's clinic. Hopefully, using these tools will move us away from the shaming, blaming language as providers and hopefully help patients continue seeking improvements in their own health. Hopefully, we can get rid of non-compliant as a label soon. Absolutely. And I shared in the references, I pulled this up and I actually remind my colleagues of this on occasion uh, that some of the language that we've used can help perpetuate some of those misconceptions. And so we really want to be careful that, yes, for example, we do know that adiposity is a large contributor to type 2 diabetes, but we also know that there's a personal threshold. There's a personal adiposity threshold for different people where these metabolic manifestations declare themselves. So it isn't a one size fits all with anything by any means. But what we want to do is we want to keep the eye on the prize that, if we can support achieving glycemic targets, support modest weight loss, support cardiovascular risk reduction, smoking cessation, making sure albuminuria is in check and under control, we can essentially decrease the risk of long-term complications attributed to diabetes. And this has been shown nicely in some large registry studies as well. Let's hear from Felix Patel. I always involve patients as part of team decide what's best treatment for them. I agree completely. I probably learned this first during my early years from my own mom, who had type 2 diabetes. And, when I was trying to share with her all the latest and greatest, it was mother knows best. So sometimes patients know best. And it's up to us to try to bring it out of them to again, become a partner. Long-term effects for GLP-1 receptor agonists. This is actually an area I think of strong interest. So the very first GLP-1 receptor agonist, exenatide, was improved back in 2005. So we believe that there's enough long-term safety data that we're not going to be caught by surprise by something untoward. But what we don't have a full appreciation of is that the newer generation of agents are so much more potent than what we were used to in the early years. So, for example, one long-term effect that we don't fully have the answers of is if people stop the therapy, what happens? We know that in the short term, the weight starts coming back, the blood pressure starts coming back, the inflammatory markers, lipids, they all start coming back. So we know that if we stop the therapy, things start reversing back. But there are still a lot of unknowns for it. So, for example, we know that some of the more potent agents are associated with weight loss, and we know that whenever there's weight loss, you lose fat mass, but you also lose lean body mass or muscle mass. So, what is the long-term effect from a nutritional standpoint, from a muscle mass standpoint, from a long-term morbidity standpoint? We have reassuring data from the longer-term outcome studies, but we also have to realize that those are of a select population of people who are in good enough health to volunteer for and be a part of these studies. When to stop or taper off GLP? So what an excellent question. These are, my analogy is that, we're not treating an infection where you're giving an antibiotic for 5 days and then see you later infection. We are handling chronic disease. And so these are chronic therapies. Treatment of diabetes, treatment of obesity is chronic management. So when I start the GLP-1 receptor agonists, I don't pose them as short-term treatments. I say, this is treating the underlying disease. The exception to that is I have seen, and colleagues have seen, patients early on, when you start a GLP-1 early on in the disease course, and they're able to see some benefit. There are patients who do revamp their lifestyle and, rediscover the joy of exercise. They start walking their dog, getting on the treadmill, going to the gym, and, swapping out huge changes in their diet. And then, you'll start seeing A1Cs of less than 5.7. And we've seen this in the trials too. for them, it becomes a shared conversation of if they want to see how they are off the medication, we can let's go ahead and taper it to the smaller dose over the next month or two and see how you respond. And guess what? We have markers, we have glucose, we have body weight, we have lipids that we can follow so we can see how much that they've been able to reverse the underlying disease on their own. The ADA put together a consensus statement talking about remission of diabetes. And in general, the consensus there is if someone remains with non-diabetic A1C levels, meaning A1C less than 6.5% off medications for 3 months, then you can say that they are technically in remission. So long answer to this really excellent short question. And colleagues, please feel free to share when your experiences with trying to taper or stop GLP-1s. So Veronica Maxwell, good afternoon. What can be done to prevent weight gain when meds are stopped? I think this, again, is where our studies are lacking but are needed. I think we need to be having a more integrative approach. It's not either the dietitian or the medication. This is where I think kind of working together and integrating lifestyle and seeing what are sustainable lifestyle behavior changes that maybe having the GLP-1 on board helped introduce the patient to will make a difference. So not a one-size-fits all answer there, but something you can pilot with your patients. But in general, just like we treat hypertension with chronic disease therapies, we do tend to view these agents as chronic therapies. I love it. People are starting to share their own experiences. Christine saw a patient on Byetta, so exenatide, 5 micrograms BID, who had been going low on a sulfonylurea. She came back in 1 year with 100-pound weight loss. Ooh, totally happy to not have lows she had to overeat for, and her life was so much easier. Yeah, don't forget, it's not just adding medication, but when you're incorporating a GLP-1, look at their other regimen. If they're on a sulfonylurea, chances are you'll be able to wean down, if not to off. If they're on insulin, there's a good chance you'll be able to wean down. Muriel, how to get insurance companies on board to continue meds when goals have been achieved. Constant fight. I know. So I think the best thing I can say here is we also have to realize is just like there's people behind all of what we do, there are also people who are making those decisions at the insurance end. So I think the more we can advocate and bring forth the patient story and the data combined, the higher the chances of getting everyone on board. But I agree. It's a struggle. It's a frustration. And I think all the outcomes data that we're seeing, not just in diabetes or diabetes prevention or cardiovascular outcomes, but also now sleep apnea, osteoarthritis, all of these will make a difference in terms of building the evidence for justification of longer-term therapy. Combined SGLT2 and GLP-1. Okay, so this audience is really, you guys are part of the future. This is such again, an important area. We don't really have studies looking at co-initiation of both at the same time, but adding one on top of the other. And what we're seeing so far is that they're both true to their profiles. So if you just look at the Venn diagram of cardiovascular outcome studies, GLP-1 receptor agonists help reduce ASCVD. They help reduce the risk of stroke. They help really target obesity. The SGLT2 inhibitors are really strong with renal protection and reducing the risk of hospitalization for heart failure. The person with diabetes or kidney metabolic conditions are at risk of both. So we really do believe that they are complementary and yin and yang with each other. The ideal cardiometabolic regimen is an SGLT2 inhibitor, a GLP-1 receptor agonist with a little foundational metformin if needed. Excellent. But some of this requires, again, tweaking the current regimen rather than, adding. Muscle mass improvement and type 2 diabetes. So this is another very important and timely area of consideration. So I think what's important to realize is lifestyle counseling is an important part of every stage of the continuum of diabetes management. But when we're incorporating the GLP-1 or the dual GLP-1 GIP agonists, it's important to talk about muscle mass. I tend to start initially really focusing on making sure that the medication is tolerable. So these medications will make you feel fuller faster, stay hydrated, smaller meals, ginger chews if need be. And then as they start seeing the benefit 3 to 6 months, that's when I start honing in on making sure that there are muscle resistance exercises that are part of their routine. At least, twice a week on a weekly basis. And those muscle resistance exercises can take any way, shape, or form. It could be stretch bands, it could be chair exercises, it could be yoga, it could be Tai Chi, it could be Pilates, it could be a stationary bicycle, which really focuses on your large muscle groups. And then as we start getting fat out of these organs, so as we start removing fat from the liver, fat from the muscle, you start improving, insulin sensitivity. So again, I think that's part of the disease regressing capabilities that is really a hot topic area of research. Patrick, patient had worsening kidney function and just suffered a heart attack. We both agreed that we needed to intensify therapy. Yeah, sometimes it takes an event to realize, again, what are our care priorities? And our care priorities for our patients remain the same, helping reduce the risk of complications. And we are in a disease-modifying era with some of the therapeutics that we have in terms of being able to preserve and protect kidney function. What's kind of neat for those of you who have been utilizing the GLP-1s and the SGLT2 inhibitors for the last few years is, if you look back at just basic kidney function, eGFR, if you plot it out over time, before we used to see steady declines over time, but anecdotally, I'm sharing, it's been really exciting to see preserved kidney function by eGFR and albuminuria. So I think we're learning a lot in people who already have advanced disease, but what we're seeing with every generation of trials is that, the earlier we can address some of these risk factors, the greater the potential we have for the later outcomes. And we are nearing the end. So let's see, I'll take this one last one. Today, NP had question on diabetes patient with recent DO with DKA, was on metformin and options to add, decided on Jardiance. Okay, got it. So the one thing to be aware of is if your patient is at risk of DKA, then you want to kind of have a little bit of a pause with the SGLT2 inhibitors just because of the literature reports of higher risk of DKA, particularly, especially, again, in off-label use in type 1 diabetes or those with more insulin deficiency. So that would be a caution consideration. I want to end on a bright note. So let's end on a bright note. I think the common themes that we've seen today is that diabetes is complex. We've got lots of options. The dialogue, the language, what we use in education is important, not just for each other, but with our patients. They're part of a journey. And the bumps that we see are really the opportunities. And, we have potent agents that can help support the goals, not just for diabetes, glucose, weight, cardiovascular risk, but we also have potent technology in terms of CGM so that patients can see their own data. And with that, I want to give you my personal applause for educating each other and me this hour. Thank you.